And I just for my own sake, I kept asking it every step of the way. Yeah, I just, yeah, but I'm holding on to work now.
Good. Just want to make sure. Stop by this morning. Did the letter make sense?
But if you guys Alright, that's great. I heard that RFP's coming out.
conversation. So I'm not saying it's impossible, but I just think that, you know, we, as an industry,
You got questions from them? So you could go around to the other elevators, or you just on the right side.
We never know until she gets out of the house. But it's that's a good sign for us. They all pretty much do the same. I think during the entire time, as I was walking, that's the only commercial I was ever, and I actually stood there and watched the entire commercial. And then when it came on again, I watched it again. How are you?
guess we need to take we need to call roll. Okay, so we're gonna start with Senator Steph.
Morning, Madam Chair, members of the committee. Turn the mic on and get started. So this morning I'm presenting Senate Bill 882. And it's a pretty simple bill that explains that a prescriber may authorize a registered nurse or licensed practical nurse to initiate a protocol for prescription refill of a Schedule IV controlled substance. What's a Schedule IV controlled substance? It's a prescription that's refilled for a maintenance medication prescribed by chronic long-term conditions and the medication taken on a regular reoccurring basis. Prescription refill is for no more than 90 consecutive days. So it's not an opioid, it's not a drug type pill. It's like a Lipitor.
Oh, this is Patty.
The doctor has to have
Subcommittee room is in here.
a qualified practitioner,
Thank you.
patient relationship with the individual to refill the prescription provided, the standard protocol written and maintained by the prescriber, and then the written order of the prescriber for the registered nurse or licensed practitioner to initiate the protocol. So there's a lot of bounds on this. It's not for a truly schedule, I guess it's 1 or 2 drug. This is for just a maintenance drug like Lipitor, Crestor, things of that nature. Now, after talking to a number of doctors, I found that they pretty much pass this on to their nurses or receptionists or somebody at that level already with a little code when they do the electronic prescriptions. However, the law states that only a doctor can sign the prescription. So what I'm trying to do is put the bounds where a licensed practical nurse or registered nurse can actually do it for the doctor based on the protocol, the medication, and truly just do it for maintenance medications. Are there any questions?
Is there anybody that wishes to speak in favor of the bill?
Mr. Chairman, members of the committee, Scott Johnson for the Medical Society, we support the bill, and I think Senator Steph meant to say it's Schedule 6, not Schedule 4.
Oops. I'm sorry. Yeah, I got my IVs, VIs mixed up. I know it's Super Bowl 52.
Andrew Lamar, on behalf of the Virginia Nurses Association, strongly supported. Thank you.
Does anybody wish to speak against the bill? Any questions from the community? Is there a motion? Second? All in favor? Aye. Thank you.
Madam Chair, members of the committee, thank you.
Senator Chase.
Good morning, Madam Chair, members of the committee. Good to see you all this morning. I'll be presenting Senate Bill 721 that has to do with healthcare services and payment estimates. Basically, Senate Bill 721 requires hospitals and practitioners licensed by the Board of Medicine to provide a patient or the representative of a patient scheduled to receive any non-emergency, and I want to emphasize non-emergency procedure, test or service to be performed by the hospital or a practitioner that at least 3 days in advance of the date of such procedure, test or service, that an estimate of the payment amount for which the participant will be responsible for such procedure, test or service would be provided. And that's just to help people who have families and need to budget to have an idea of what that's gonna cost. Under the current law, the requirement to provide such estimates applies only to hospitals and elective procedures, tests, or services. In every other industry, you know the cost before you choose to buy, except for in healthcare. You would never call a plumber to your house and have him perform services and then find out what it's gonna cost. Yet in healthcare, we've allowed that to happen. And while I understand my bill is very simple, this is not a simple issue, it is very complex. The goal of this bill is to provide greater cost transparency to the patient before services are rendered, so they can plan the expense in their family budget, shop around, or decide it's simply not worth the cost to them to have the procedure done at that time. Many construction contractors, insurance agents, I know back when I was in financial services, I would spend hours educating potential consumers about information as it pertained to their finances, and I spent hours doing that and didn't get paid a dime, honestly. So I spent hours with a potential client educating and explaining a service and an estimated cost of services. It's simply considered the cost of doing business. Yet under the current system, the healthcare industry has been given a pass. If you have insurance, you're asked to sign the dotted line saying that you'll pay whatever insurance doesn't pay for, and most of the time you have no idea what that estimated cost of service is. Would you sign a blank check and give it to your doctor? That's basically what we're doing, and I want to give the patient, the consumer, the opportunity to know how much before they commit to services. This will also allow you to compare and shop services. Doctors feel like the insurance companies own them. I hear doctors complaining all the time that practicing medicine is no longer rewarding anymore. Why? Because they feel like insurance companies are dictating to doctors what they can and cannot do, ultimately holding our doctors hostage to a broken system. I have to give special thanks to former delegate John O'Bannon, who is behind my bill. Cost is the single biggest obstacle that is preventing most people from being able to afford healthcare on their own. Notice I said healthcare and not healthcare insurance. I want to make sure that people have health care. I know a lot of times we talk about healthcare insurance, and I know lots of people who have healthcare insurance, but they have no health care. Whether we expand Medicaid or not, the cost of health care is only going to exponentially increase if we don't do something about it. We must address the underlying issue of why so many cannot afford health care. It's the rising cost. So what are we going to do about it? Wait until no one can afford it? Many doctors are turning to models like Partner MD. I also would like to comment that dentists are already doing a great job at this. So that would conclude my remarks. I would say that, I know in talking to a number of you that you've expressed concerns. I have people in my community who are in support of this. I have doctors who have expressed support of this. I'm actually going to today ask that, I work with the Virginia Hospital and Healthcare Association. I worked with a number of the stakeholders, Scott Johnson, Trip Perrin, the list goes on, and met with groups of doctors with the Virginia Eye Institute. I mean, I've spent a lot of time over the summer to try to get a hold of our healthcare costs and what we're going to do about it. One of the things that is currently available in the code is, trying to find it here. Under section 54.1-2963.1, there is a disclosure of medical treatment options, and this is already on the books, and it says that any physician shall have the authority to disclose fully all medical treatment options to patients, whether or not such treatment options are 1, experimental or covered services, 2, services that the health insurer will not authorize, 3, the cost of the treatment will be borne by the health insurer or the patient to facilitate an informed decision by the patient, if the physician determines that such an option is in the best interest of the patient. Any physician who discloses information concerning other medical treatment options to a person with whom he has established a physician-patient relationship shall not be liable to any health insurer in an action instituted solely on behalf of the health insurer for any civil damages resulting from the disclosure of such information. This section shall not affect any cause of action a patient may have against a physician. And for the purposes of this section, medical treatment options means any alternative or experimental, therapeutic, psychiatric, medical treatment, or procedure, healthcare service, drug, or remedy. I have agreed to pass this bill by for the year if I can get an agreement from Dr. Brown, if he will honor the intent of what my bill is trying to do and write a letter to all healthcare providers to ensure the current law is promoted so that this estimated cost of services will be provided as a best practices. If I go to my doctor this year and I ask them, what is this gonna cost? And they give me the deer in the headlight look. I know that we have not fixed this problem. I think this is a great consumer advocacy initiative. It's already in the law, but it's not being done. Physicians should provide this to the consumer. Whether you have insurance or not, the patient should know how much it's going to cost before services are rendered. Wouldn't it be great to, when you make an appointment with the appointment secretary, when you need to see your doctor, to ask potential patients who call in and schedule an appointment, would you like for us to provide you with an estimated cost of services for your non-emergency procedure or visit for your budget planning purposes? The orthodontists not only provide an estimated cost of service, many other payment plans as well for their patients. We need to think outside the box and create an expected environment of transparency within our doctors' offices across the Commonwealth. If we want to provide affordable health care for all, then we must address the cost. Healthcare cost transparency will allow everyday Virginians to be better informed about costs associated with healthcare so that they can make more informed choices for their families. That is my presentation.
Are there questions for the patron? No? Is there anybody that would like to speak to this bill in favor or against?
Good morning again, Madam Chairman. Scott Johnson for the Medical Society. I want to thank Senator Chase. We've had numerous meetings with many stakeholders from the Hospital Association and the Dental Association and the Medical Society all through the summer. And she is correct. We committed to her to work with Dr. Brown to find an efficient way to communicate to members to say, we want you to be transparent. We want you, when patients ask, what does it cost, to try to do your best. It's not as easy as giving them a sticker price number, because you have to figure out if the patient has a high deductible health plan or what co-pays would be, and if you participate with them. I did ask Dr. Harp at the Board of Medicine, have you had any complaints where a physician refused to tell a patient when they asked, what is this gonna cost? And to his knowledge, there were none. But we want to have the educational front, not only through working with Dr. Brown and the Board of Medicine, but also through the Medical Society's communication. And we appreciate Senator Chase helping us along those lines, and I'll hand off to Mr. Rawlins.
Can I ask a question real quick?
Yes, Senator.
Does the doctor actually know how much this is gonna cost, or does he have to have this financial?
Oftentimes, the doctor himself or herself does not know, and you have to ask your business person to say, can you help me navigate this? Sometimes you have to even contact the insurance company to see if you can find things out. So it's not easy as a 1, 2, 3.
And Senator Fairclough, I'll comment on that. The challenge here is when you go in to purchase tires, the person who's supplying the tires are in control of that pricing, and they're passing that on to you. And you have a relationship with them for that purchase. When you go in to see a physician, your actual relationship is with the health plan. And the health plan is the one that's accountable for what your copayment is and what your deductible is and all those other variables. And we are a small business, Scott. What percentage of the business in Virginia is medical practices? We've talked about this before. It's like
narrow
number
wedge.
3 for small businesses in Virginia, and they have a really high level of work that they have to do to assimilate the relationship between the patient and the insurance company, for which they do not get paid when it's not even their relationship. But in advocacy for the patient, they do that. But to be held accountable dollar for dollar, we can tell you what our price is. We can't tell you what you'll have to pay, because that is an agreement you have with another organization. And that's the challenge, is that this isn't the same kind of marketplace. And so I think that doctors already do this. Before I do a procedure on anybody, they meet with the people that deal with insurance and payment in our office, and they relate to them what the insurance company said, but we don't have the power to make the decision, so the accountability would not fall into our realm either. So, that's the challenge here. So I'm sorry that
So another question for Dr. here. So will this increase the cost if you have to then establish a patient finance consultant before we do work?
this will absolutely increase the cost and the strain on the small businesses that are your physicians, but unlike the tire salesman, I cannot pass that on to what I charge, because I'm capitated by whatever the insurance offers. So you're gonna see more people. You talk about doctors being disengaged with medicine and all the pressures that ensue, this would just be one more regulation that we have to abide by. That the intention is great, the aspiration for transparency is great. I wish it were something we could fix this easily, but I think that there are untold ramifications of mandating something like that.
Madam Chair, and just to follow up on your comments, I think, the big problem here is that, nobody in the medical industry knows when the patient comes in, what their, where they are as it relates to their health insurance plan. There may be a few plans where you have a pretty good idea, but in many situations, you don't, because you don't know where they are on meeting the deductible, what their co-pays are, a lot of those types of things. And the concern I have is that basically, if the provider is having to get all that information to be able to provide it to the patient, it does have some cost to the provider to do it. They're not in a position to be able to get the insurer to pay them more for the information the insurer is now provided to the provider, so the provider can provide it to the patient. And so, and if you wanted to make it fair, what you would do is then say, okay, the insurance company now has to pay more, which drives up the premium, so it's sort of almost a never-ending cycle there that, does cause some concerns. I mean, I understand exactly why people want to have some idea, but I think that this is not necessarily the most effective way to do that right now, so.
And we had other people to speak, and we're gonna be quickly, because she's proposed PPI, and we've got other committees.
Just, Mr. Chair, members of the committee, Madam Chair, members of the Brent Rawlings, Virginia Hospital and Healthcare Association. Just echoing the comments here, the one thing I'll say is that with respect to hospitals and health systems and our various settings of care, we do a pretty good job, I think, in terms of trying to counsel patients, especially with some of their larger procedures and the financial implications of their decisions. But as has been reflected here, we don't have all of the information available. So, we're interested in doing our part and helping to promote transparency, recognizing that there are gaps in the information that we have and our ability to help folks as much as we'd like to. So thank you for listening.
Madam Chair, if I might just put in a brief plug. I'm a patient of Kaiser, which actually is the insurer and the provider, so actually I get the information because they're all one and the same, but most providers are in that situation.
I guess just one last comment I would like to make on that. In my bill, it basically says that you give the provider 3 days notice. I mean, they're gonna have to pull the billing anyway to figure out how much you're gonna have to pay. It's just a matter of making that more of a priority, doing it before the appointment instead of after the appointment, so.
And I would suggest we do that now for procedures, maybe not for an office visit, but if you're having a procedure that requires authorization or prior authorization. And I think we're gonna be getting to this in some of the shared savings legislation that we're talking about, but that's done more through a portal with the health plan instead of the physician. So,
Madam Chair, just one comment. Senator Chase, I appreciate what you're doing here, and it has for years driven me crazy. In my professional life as a lawyer, a lot of times we're negotiating settlements based on what's charged or billed or not, and you'll find somebody with insurance is billed $30,000 for something. Somebody with insurance is billed $2,000, and you'll find this at hospitals. And so I understand the doctors cannot come up with a cost because every plan is different, but you would think that they can at least tell you what the standard price is. You're gonna need a knee replacement. This is the standard price. Then we're gonna have to work it down based on this plan or that plan or that plan. I'm not convinced that they have a standard price for every procedure or for various things that are done. And it just seems to vary depending on coverage, not coverage, this. I don't, just at least tell us what the price is that you're gonna tell everybody. And so I would like to see that, and I hope that this will be stressed to the healthcare provider. So thank you for bringing this.
okay, so is there a motion?
Yeah, I would vote for
We can do that too.
All in favor of PDI, signal by saying aye.
Aye.
All opposed? Okay.
Thank you.
Thanks, Senator Chase.
Thank you much.
All right, Senator McClellan.
reduced fee to a prescriber in a nonprofit facility to dispense, basically contraception and STD, treatment medications. And that's the bill.
Are there questions from the committee? And
But this is the one we heard last week that they went back to the drawing board on.
It is, and we have heard and had discussion on this, so if there's anybody that wants to comment briefly, but is there anybody opposed to the bill? Okay, is there a motion? Oh, I'm so sorry. Yes, comments.
Caroline Turner with Board of Pharmacy, just letting you know that the administration supports the bill.
Thank you,
Substitute.
Caroline.
Nicole Piabar, ACOG, Virginia, we support the bill.
Thank you so much. And if opposed, absolutely.
I'm Josh Hetzer with the Family Foundation, and I will we still oppose this. So just getting this new substitute, I hope there'll be an opportunity to see what, to talk about a little bit what's in the new one.
Sure, I mean, if you want me to just kind of explain, so what all the bill does now is allows the Board of Pharmacy to have sort of a reduced price, permit for a clinic, to allow them to dispense birth control or STD medications without having a pharmacy on site in the clinic.
So I think the bill before had proposed that the clinics be a carve out where they would not have to be licensed by the Board of Pharmacy to dispense, they're already prescribing. But the question is, would the patient have to go to a pharmacy to pick it up, or could they dispense at the clinic? And this changes it so that there is accountability. They are licensed through the Board of Pharmacy like everybody else, but they are able to dispense there. There is some data to support that. That's a very important concept for continuity and reduces the risk of abortion or unintended pregnancy. And when you're able to dispense 12 months at a time, there's a randomized double-blinded trial that we looked at last year, that this actually reduces the risk of unintended pregnancy, because one of the hardest compliance issues for women is picking up the next pack of pills or the next 3 pack of pills. So this would allow them to dispense also to treat STDs. We do have chlamydia and other things on the rise, and it is sometimes hard to get that treated. So I do think this is a good health initiative for a needy population that still has accountability. Was there anybody else that would like to speak? Is there a motion?
I make a motion to recommend support.
All in favor, signal by saying aye.
Aye.
All opposed?
Thank you, I want to thank Senator Donovan for helping us.
Okay. And Senator Edwards.
I'll start with Senate Bill 222. This is a bill that is not a joint commission on healthcare bill, but it was studied for a couple of years by the joint commission on healthcare. And what it does briefly is to resolve issues that are in the code when it comes
Hello, is this
to
Senator Vogel's office?
a situation where a doctor
Is she gonna come present her bill to the Health
continued care
Protection
be
Subcommittee?
medically inappropriate and morally
It's going on right now, and she's next.
ethically objectionable by a doctor of the hospital.
Thank you.
Somebody alive. The law, right now, the Virginia Healthcare Decision Act is silent as to what to do in case of an unresolved disagreement between families on the one hand and the healthcare providers on the other hand. It happens occasionally, not very often, fortunately, but when there's a unresolved disagreement, what do you do? Right now it is silent. What the bill does is to establish several safeguards not currently in the code to ensure that physicians and hospitals follow a set of common rules to resolve the conflicts between families over the appropriateness of life-sustaining treatment options for very seriously ill patients. The second thing it does is it gives a 2-week window provided in the current, if the 2-week window provided in the current code to resolve these situations passes without consensus, then it provides clarity as to how the position is perceived. Currently, the code is silent as to what to do during that 14-day window. There are a couple of amendments I would like to add before we go forward. One. This is, well, let's see, the first one would be, want to read them?
Thank you, Mr. Chairman. On line 216, after word B, insert medically, so read be medically harmful or medically ineffective.
So, Senator Carrico, so on line 216, when you're adding being medically harmful, how broad is that making the definition now?
Does it go before here
Or harmfully medical?
There should be two.
Okay.
I think the contrary is the, after C, I believe it is, C, B, medically contrary. Yeah, I think it's C, it's the second B, two B's in it.
Yeah, or C, be medically contrary to the clearly documented wishes of the patient. Are there any other amendments, Senator Edwards?
Yes, the ones that I come up with, that would be on line 214, where it says, the physician may cease to provide the treatment that the physician has determined to be medically or ethically inappropriate. Add the language subject to the right of court review by any party. That'd be 214, subject to the right of court review by any party.
Are there any questions about that amendment from the subcommittee? Well, do you have any more amendments?
And then, yeah, another one, which is similar to that, one, if you go back to 156, where it provides, that, nothing in such policies, the policy established by the hospital, nothing in such policy shall prevent the patient, his agent, or the person authorized to make medical decisions related to such and such from obtaining legal counsel to represent the patient or from seeking other remedies available at law, including seeking court review.
Any questions about that amendment? Is there a fourth amendment? Alright, so we've got this three. I was gonna say, that's an important one, especially for the libertarians. Is there, second, and so we're gonna take them up in a block. Speaking to the motion, Senator Carrico.
Let me just add, I know I'm chair of the Joint Commission on Healthcare. I know that the Joint Commission, and you're, Senator Edwards, on it too. I know that there's been a lot of involvement in this study, and I think what we're doing now with these amendments, adding some of the things is not some of the agreements that were made in the study that's going on. I think that there is an amendment that could be made to this that would bring most everyone into agreement, but I don't think this is going to reach that point, because I think when you start adding language especially after the subsection C, adding medically, find it here. The first amendment that was asked for, in subsection D, medically contrary to the clearly documented wishes of the patient, I think was where he was asking for that first amendment. I think we're heading down the wrong path of giving all the discretionary to the doctor and not to the patient. So I would oppose the amendment, but
I'm going to amendment to the amendment, where under the two Bs, I'm advised
Which line, Senator Edwards?
On line, 216, where it says smaller B, B adds the word medically harmful. That's what it was supposed to be.
Still, Mr. Chairman, I think we're still making it very discretionary on the doctor's part, not on the patient's part.
I think there's a good chance that this bill's gonna have a challenge, today. But what we have before us is the motion on these amendments. Is there any more discussion on these amendments before, and then we'll move on to the bill itself?
Yeah, just
Senator
quickly,
Barker.
I think the two provisions, in addition to the second and third amendments, do provide for clear protection for the patient and the patient's family, softening the patient's family.
I think the last two.
Senator Carrico, Senator Barker, you finished? Senator Carrico.
I think the last two, without really looking into it any deeper, I don't see the last two being as much of an issue as the first one.
Well, I think we're gonna have a little robust discussion in a minute on the bill itself. We've got the amendments before us. Senator Barker.
Given comments of Senator Grayson, I would suggest that we split the amendments and go separately on that.
All right, so Senator Barker and Senator Lucas, I believe, have withdrawn the motion for the amendments in a block. Senator Barker, would you like to make a new motion?
Yes, I will move the three amendments and ask that they be voted on separately.
All right, so the first amendment, council, can you make it clear so everyone knows what we're voting on? Which line item? Please report amendment 1.
Line 216, after the first B, insert the word medically, so it would read, be medically harmful or medically ineffective in prolonging life.
Okay. As many as favor adoption of amendment 1, signify by voting aye. Any opposed?
No.
All right, amendment 1 fails. Proposed amendment number 2 is now before us. Council, please report amendment 2.
So on line 214, after inappropriate, insert subject to the right of court review of any party, by any party. So that would read, cease to provide the treatment that the physician has determined to be medically or ethically inappropriate, subject to the right of court review by any party.
So, Mr. Chairman.
All right, Senator Carrico.
I believe if I'm right, and maybe council can tell me, is with this language, it allows either the patient or the hospital to be able to have a court review of what the status of the patient is.
Yes, sir.
So, proposed amendment number 2 is before us. As many as favor its adoption will signify by voting aye.
Aye.
As many as opposed. Okay, so amendment 2 has been adopted. The third amendment, please report that, council.
So on line 156, after at law, insert including seeking court review. So that would read, nothing in such policy shall prevent the patient, agent, or the person authorized to make medical decisions pursuant to section 4.1-2986, from obtaining legal counsel to represent the patient. Represent the patient or from seeking other remedies available at law, including seeking court review, provided that.
All right, so the third proposed amendment is before us. As many as favor its adoption will signify by voting aye.
Aye.
As many as opposed adoption will signify by voting no. All right, that amendment is agreed to. So we now have, the amended bill before us after the adoption of amendments 2 and 3.
Mr. Chairman.
Carrico.
I would also like to offer an amendment, would be found on 183. After, persistent vegetated state, comma, strike the comma, and the remaining amount of 183 and 184, up to the period. this would, I'm striking out the language except to the extent that such factors relate to a patient's medical condition. I think that is so broad that we give so much leeway because of a medical condition. And I think if this is out of there, we can come to at least an agreement that this is something that everyone, I know this has been a prolonged study that has had all the stakeholders at the table, and I think that they have made a lot of progress in this area. And I think that with that broadness of that language, it's going to be very hard to support, and kind of takes away from everybody who was at the table talking about this very issue. So I would make that motion that we strike that language out.
So we've got, that motion before us, for the amendment as described by Senator Carrico. Senator Edwards is the patron. Is that agreeable to you?
That's agreeable to me.
All right, and Senator Barker seconded it. Any more discussion? As many as favor adoption of this fourth proposed amendment, please signify by voting aye.
Aye.
Opposed, no. All right, that has been agreed to. So we now have the bill before us with the proposed amendments. Senator Edwards' second and third have been adopted, and Senator Carrico's fourth. It's now time, unless anyone has any more amendments, that we are going to move to public comment. I don't want to put the clock on. How many folks do we have that feel compelled to speak to it? Okay, so what we will do, what we're gonna do is, for the first 5 minutes, it'll be on a clock, to speak in favor of the bill. Keep in mind that that's 5 minutes for the entire side. So if Senator Edwards has someone that he definitely wants at the front of the line, please have that happen. Well, there'll be 5 minutes for the entirety, and then we will hear 5 minutes from those that have concerns or issues with the bill. And then after that, we'll move hopefully to a motion of action by the committee. So, do you have the ability to do the clock? All right. So we're gonna start, and when you come up, please identify yourself and any affiliation. So.
Hello, my name is Rhodes Rittenauer. I'm the Vice President of External and Regulatory Affairs for Bon Secours. On behalf of our more than 14,000 employees and more than 600 providers, we're here to support the bill. And I've got with me our Vice President of Ethics and Mission, who gets called in on the very complicated cases near the end of life to talk about how it works at Bon Secours and why we support the bill. Kelly Stewart.
I'm going to read fast. Since transitioning my medical practice to full-time ethics consultation and teaching for Bon Secours, I've been involved in about 25 consultations each year relating to medically inappropriate treatment demands at the end of life. By medically inappropriate, I mean the intervention will likely inflict pain or other harm and has sadly no reasonable expectation of restoring sufficient health or organ function to the patient that he or she will ever leave an intensive care unit or hospital or enjoy restored health. Families who are facing the death of a loved one often have no medical expertise and find navigating the complexities of healthcare overwhelming. In addition, many have unresolved family conflicts, stressors, and regrets that influence their ability to deal with grief and loss. These families deserve our sensitive consideration, but the patients should not suffer. Current statute has created circumstances in which the entire healthcare teams are required to participate in escalations of technology that they believe are tantamount to torture in prolonging the dying process, and many healthcare professionals, especially nurses, leave the profession for this reason. We have a nursing shortage in Virginia. At present, if a family member insists, providers are required by law to apply interventions that they know are medically inappropriate, regardless of their professional judgment that the intervention is harmful, if that intervention just keeps a heart beating, and the law gives no remedy. This bill provides a robust process that both protects vulnerable persons and acknowledges the limitations of medical technology. The process in this bill was created over several years by a collaboration of hospital groups and patient advocacy groups. Advanced care planning is helpful and recommended, but it is not enough. Many people do not have access to or understanding of advanced care planning, and improving this circumstance will take a long time. You may ask, why should I care about this? Why don't we throw every medical intervention at every patient? There's one simple answer. We don't get do-overs in death. We have one opportunity to uphold human dignity. How we die matters.
Mr. Chairman. Kelly, can I just ask you a question? Having been an ICU nurse before a physician and dealing with these end-of-life issues, we never had a situation where we couldn't reach consensus. So we called in the ethics team and we sat down and we were able to reach consensus. The challenge for me with this bill is that the physician has the last say.
No, it's not just the physician. In our process, for example, we have a team of experts that get together that include physicians and other medical experts.
That's your situation. I'm talking about the bill though. In the bill, if there's no other recourse and the physician says, I think this is unethical, there's a singularity in that because the family doesn't agree. And I think for me, in trying to resolve those end-of-life issues in a beautiful way, if we fail to reach consensus, I'm with you. I'm worried about, it's very hard to be asked to do something that you think is unethical. Most of the time, doctors have the prerogative of saying no and passing that patient on to somebody else. And I know there are physicians that genuinely get stuck here, but I think that's the snag with this, is that we are legislating that there's a unilateral decision-making process.
Because the bill requires that we give certain kinds of information to the family, and because the bill requires that we cooperate in their efforts to seek other remedies, that by definition means a doctor can't do it by himself. So it has to involve other hospital resources, by definition.
Thank you. We're gonna, the clock was stopped, and we're gonna restart it right here. Doctor, you're up.
Hello, my name is David Davis. I'm a doctor and lawyer. I work at Curlian and Roanoke. One part about the continuing the care when it's ineffective is the issue of moral distress. Curlian has 3 full-time employees that deal with moral distress among their staff. That's defined as, we know what's the right thing to do, but we feel powerless to do it. This is a big problem. Curlian right now has 5 patients in this condition. I'd like to speak also to the idea of recourse to the civil courts. I was involved in advanced directive legislation 20 years ago. That was at the behest of the civil court judges who do not want these cases in their courtroom. They do not. We have due process in the hospital. It's with a medical ethics consult group. It's all facilitating. When they do go to court in Roanoke, it goes to a magistrate. They invariably want to kick the can down the road. They want to say, let's give it a little more time and see what happens. Meanwhile, we're losing nurses and doctors and respiratory techs and house cleaning people to burnout. This is a bigger problem than people know, and I urge you to support this bill. And if we do have to go to civil courts, let's do at least give a presumption to that magistrate that we are doing the right thing, that we've had due process, and that we're doing it in good faith. Thank you.
Thank you, Mr. Garland. From one of others in support?
Thank you, Mr. Chair. Over the subcommittee, Bill Ray with the Virginia Catholic Conference. We are supporting this. It addresses a real problem with what happens when there's conflict in treatment, and we think this includes really strong protections for the continued provision of artificial hydration and nutrition, which currently aren't present anywhere in the code, and that would be a dramatic improvement. We would like to see the amendment that says it shall continue to be provided unless it's medically harmful. I think that would actually make it less broad and more specific to include that modifier in front of harmful. Just having harmful, we think would make it too broad. I think it still could be salvaged, hopefully, and maybe I can stop by some of your offices and discuss that further if it's the subcommittee's pleasure to pass this. I hope it is. Thank you.
All right, thank you. So that's the 5 minutes. Anyone else that's in support but feels the need to mention?
Brent Rawlings, Virginia Hospital and Healthcare Association. We support the legislation.
Mr. Chairman, Josh Esser with the Family Foundation. We've been a part of the 2-year study work group, and we are satisfied with the legislation
Chairman Olivia Turner with Virginia Society of Human Life. We were on the committee for the entire 2 years. Senator Edwards, I want to thank you for your amendments this morning, particularly access to the courts. We do think that helps a great deal to broaden the protection for patients. Dr. Donovan, Senator Donovan.
We've exhausted the 5 minutes.
Quickly,
So
I want
we know that the
Senator,
Society for
please,
Human
no,
Life
Senator,
supports
please.
it. No, because.
Senator, this is important.
I understand it's
Issues of
important.
transparency. Just make sure
And I want
there's
to hear from
transparency.
the other people too, but
Thank you.
there are several other places we have to be and several obligations. Anyone else in support? All right, is there anyone that would like to speak with opposition or concern for 5 minutes? All right, we'll restart the clock. You're up.
Morning, my name is Maureen Hollowell. I'm representing the Virginia Association of Centers for Independent Living. We appreciate Senator Carrigo's amendment. A very significant concern of ours is that the language in the bill that attempts to address concerns about disability discrimination is inadequate. On one hand, physicians would be prohibited from withdrawing treatment on medical or ethical grounds because of a patient's disability. On the other hand, we would be permitted to make a determination about the appropriateness of treatment to the extent factors relate to the patient's medical condition. This is deeply troubling, and we very much support the amendment that's been offered. We support the amendment. Our concern is with the individual who is seeking to live either by their known decision or their predetermined directive or decision of their surrogate. Considering that any treatment would end life, the notice and procedures to permit the end of treatment over the objections of the individual or the surrogate must be transparent, easy to access, easy to understand, and include adequate protections. The bill does not provide for the transparency and protection needed. The bill would have hospitals manage the decision process when there is a disagreement on these matters. So long as the hospital is independent of any monetary considerations and the physician is independent of the hospital, expanding the role of the hospital as an arbitrator before the matter goes to court may be reasonable if there are provisions for transparency and with the improved non-discrimination provisions. We respect the position that physicians and others in the medical professions find themselves when these disagreements arise. We are not advocating to torture people. We are advocating the right of people with disabilities to decide if treatment is appropriate and how they choose they want to live. Thank you.
Thank you. Others with concerns, there's about 2:45 left.
I will not take that much time, Mr. Chairman, members of the committee. I actually intended to express some concerns about this, but thanks to amendments from Senator Edwards and from Senator Carrico, I think that our concerns have been addressed.
And who you represent?
I'm sorry, I'm Colleen Miller from the Disability Law Center, and we were very concerned about protections in the bill for people with disabilities, and especially about ethics committees that might be making quality of life judgments about somebody's disability. So I apologize if I don't fire quite as fast as the members of these committees do. I think that these amendments will address our concerns, but I may.
You want us to watch that through the process?
Yes, thank you.
Thank you. All right, is there anyone else that feels compelled to speak with concerns or opposition? All right, seeing none, thank you for that. Is there a motion?
We recommend reporting.
All right, so we've got a motion to recommend that the full committee report with the adoption of the proposed amendments 2 through 4. Any discussion on that motion? As many as favor adoption of that motion will signify by voting aye.
Aye.
Opposed? And I want to be listed as abstain on that one so that we get another look at the amendments. So on that one, I think you're gonna get 8 votes out of the committee, but you might want to watch it just as the discussion on the amendments. And you have another bill before us?
Yeah, a small little bill. Senate Bill 223. I only like controversial bills. I mean, what's the fun of coming down here and listening to controversial? Anyway, this one has to do with giving the Attorney General some authority to investigate.
And is it in the form that you want us to consider, or are there amendments? Alright.
What it does, Mr. Chairman, members of the committee, we know there are a lot of egregious situations out there. A fellow named Martin, somebody whose name I can't pronounce, probably in prison now. But he jacked up the price of some HIV medication to the point of ridiculousness. We do know that there's been extraordinary increases in some cases in pharmaceuticals that were without great reason. All this bill does, is to provide that the Attorney General, first of all, the Secretary is to designate essential drugs, a list of essential drugs. The NIH and people like that also have essential drugs, say 50 essential drugs that people need to have, or whatever the numbers are. Based on a finding of their unique efficiency or efficacy in treating life-threatening health conditions or chronic health conditions that substantially impair an individual's ability to engage in activities of daily living. A list of all drugs identified as essential for the purpose of this chapter should be posted on a website maintained by the department. That's the first thing it does. We need something like that. The second thing it does, it says, upon receipt of notification of suspected price gouging, which is defined here, and any other case in which the Attorney General has reasonable cause to believe that any person engaged in or has engaged in a violation of chapter, which is defined in here, the Attorney General is empowered to issue a civil investigative demand, period. It shall, what that would mean is, and for bringing the information, take a look. Right now, there's no process for the Attorney General to investigate what's going on in the price gouging arena in pharmaceuticals, and to the extent that it happens. It doesn't give them any authority to go to court. That is separate. All it does say, I want to look at what's going on. Give me the information. Period. That's all it does. This is modeled after a Maryland law. This was passed not too long ago. And so it's very simple. Simple bill.
All right, thank you, Senator Edwards. First, are there any questions for the patron from the subcommittee?
I might have one question has come up, and that is, price gouging is defined as an unconscionable increase in price of prescription drugs, and unconscionability is defined as an excess. It's a price of a drug that is excessive and not justified by the cost of producing the drug or the cost of appropriate expansion of access to the drug to promote public health, and two, results in consumers for whom the drug has been prescribed having no meaningful choice about whether to purchase the drug at the excessive price because of the importance of the drug to the health and the insufficient competition in the market. One kind of rough example is if you're wandering through the Sahara Desert and you're really thirsty, and somebody comes along with a lot of water. Oh, you're thirsty. I tell you what, how about $1,000 a cup? That's obviously excessive. There we go.
Special price.
Yeah, special price for you. And there have been examples where this type of thing has happened. That's all.
All right, thank you, Senator Edwards. Are there folks that feel compelled to speak in support or express concerns today? All right, is there anyone, we'll start with anyone that would like to speak in support of the bill. All right, anyone that would like to express some concerns about this legislation?
Mr. Chairman, Andrew Lamar, on behalf of the Association for Accessible Medicines. I don't want to go into a lot of detail because you did hear testimony from our client last week. She was able to be here for the preceding 2 weeks, but couldn't come back for a third, unfortunately. One of the main issues being that the bill that was passed in Maryland and enacted is under litigation currently before the Fourth Circuit. So we think there's constitutional issues there that should be considered. I don't want to speak for the Attorney General, but I know they have expressed some concerns about that as well. And then secondly, just the uncertainty that it adds to the marketplace and discouraging folks from the industry to participate in the Virginia market, and the impact that might have on sort of unintended consequences of upward pressure on pricing. So,
All right. Thank you, Mr. Lamar. Is there anyone from OAG here? They usually don't. We have a lot of frequent guests, but they're usually not one of them. Okay. Others with concerns? Well, I'm glad we used up all the time on the other one, not both.
I might point out the issue of unconscionability has come up, because I've talked to the pharmaceutical people. Unconscionability is a well-defined term in the law under the Uniform Commercial Code. It basically says you don't have bargaining power. And it is somewhat loose, no question, but it is a constitutional and fairly well-established term in the law. So it's not a new term. There's a lot of case law out there on the concept of unconscionability.
Thank you, Sam Edwards. Is there a motion anyone would like to make?
Mr. Chair.
Yes, Senator Barker.
I'll make a motion to pass by indefinitely, if I may speak to that motion.
Yes, sir.
I think, I understand what Senator Edwards is trying to, the general issue is trying to get at, but I think it's particularly problematic given that this targets generic drugs where there is open competition basically in the generic market, and where the sensational cases really have been on those that are not generic, that are not in the free open market yet. So I don't think this actually gets at what have generated public concern on them.
I would agree. Senator Edwards, you want to respond?
Yeah, I would agree we should add brands as well.
Senator Barker, thanks for expressing that. I've heard that concern from several folks, including in my own mind. Is there anyone else that would like to second the motion put forward by Senator Barker?
Second.
All right. Any discussion on the motion passed by indefinitely? All right. As many as favor that motion will signify by voting aye.
Aye.
As many as oppose that. All right. On a 6-0 vote, we recommend PBI for the full committee.
Should we just go ahead and do that on Senator Vogel's bill since she's here?
No, Senator Vogel's bill.
Senator Vogel, you are all that's left on the docket.
Thank you, Mr. Chair and members of the subcommittee. Just briefly, by way of background, this is a prescription drugs take-back bill that a number of stakeholders have tried to work on through the course of the weeks leading up to session. And essentially, we do not have yet in the Valley. Everybody agrees that this is something that we need to pass. Everybody agrees in concept. But I don't want to pass a bill that everybody doesn't agree on. And so what I would respectfully request is that we send this bill to the Joint Commission on Healthcare for further study. That would be okay with the subcommittee, and that we would take the time to iron out the implementation details through a multi-stakeholder process where the pharmacists and pharmacies, retail merchants, and others who would be impacted by this would actually have the time to work through the details in a way that would make all the stakeholders happy, because this is actually a significant process, a significant program, it has a lot of impact, but at the end of the day, it's a process that we know we need to work through. We have to do something to address the opioid process, and work through a process where we can get the goods into a take-back process, but we don't yet have agreement.
All right, thank you, Senator Vogel. We've got the chairman of Joint Healthcare right here, so I'd like to hear his thoughts.
So you can decide how you care to do.
I don't see any problem with the Joint Commission on Healthcare studying it, because I think it's in the purview of what they'll do. We are, and those of us that are sitting here on that committee, going to meet while we're here after crossover to determine whether we adopt the rules that is currently in place with the Crime Commission, because what is currently happening is the Joint Commission on Healthcare is getting overloaded with bills that the commission just doesn't have the time to sit and really study and vet the bills that we're having. This is the first one that I know that has been a request to have the Joint Commission study, so I don't see that there's a problem. But I think we get overloaded by the House with the number of bills that come to that committee, so I have no objection. I think it fits the purview of that committee. I just want everyone in here, as we start debating House bills and other bills, to be mindful of how many that we've sit there and passed.
Well, and Mr. Chair, member of the
Yes, Senator Vogel.
Understanding the limited bandwidth and how much pressure there's going to be on your commission, I would just say that we're certainly committed, no matter what, during the interim, to work on this. This is a bill that everybody's committed to continue to work on, and I intend to bring back something next year. Because there's a lot of interest, there were a lot of people who wanted to co-pay through the legislation, there was a lot of interest on the House side. So we'll come back, but we're just not ready right now. So.
Alright, so I think what I've heard is a request for PBI with letter. Do I have a motion? Alright, so that motion's before us, and so what, our recommendation to the full committee would be is, that Senator Newman write a letter to Senator Carrico, a few seats down from him, and ask him to, consider this.
Right,
Right, so
Senator Carrico can
under
decide
no-
yes or no.
Yeah, they're under no bounds, yeah, they're under no bounds to do it,
Right.
but we're gonna ask joint healthcare to consider looking at it.
And we're gonna work on it anyway, either way, so
And
thank you.
that's good, Susan. Any discussion on the motion? Alright, as many as favor the motion to PBI with letters signify by voting aye.
Aye.
Any opposed? Alright, so that's 6-0, and that's what we will make the request for the full committee.
Thank you, Mr. Chair.
And that's all we've got today.